Hello everybody. Today we are going to discuss about nimodipine in SH. Nimodipine is dihydropyridine L-time calcium channel antagonist which is associated with delayed cerebral ischemia in patient with aneurysmal SH because it has been associated with the reduction in the infarction rate and improvement in the functional outcome. The guideline from the Neurocritical Society specifically recommended oral nimodipine in patients with aneurysmal SAH to reduce delayed cerebral ischemia and cerebral infarction rates and to improve functional outcome. The American Heart Association and the American Stroke Association guidelines suggest that in patients with aneurysmal SH, the early initiation of enteral nimodipine is beneficial in preventing delayed cerebral ischemia and improving functional outcome. Nimodipine reduces the risk of death and the vegetative state. Because of its vasodilating property, nimodipine would decrease angiographic cerebral vasospasm and its consequences. It also help in reducing cortical spreading depolarization, increasing endogenous fibrinolysis, and it also helps in reducing cerebral microthrombus formation. So if I want to summarize the potential mechanism of action of nimodipine, it will be first vasodilation, then it had some anti-inflammatory properties, it had some antithrombotic property too, and it will reduce the cortical spreading depression inhibition. Then it has overall neuroprotective property by reducing endothelial neurotoxicity, intracellular swelling, oxygen-free radical, and intracellular calcium influx. Now about pharmacokinetic and pharmacodynamic. Nimodipine is rapidly absorbed after oral administration. Peak concentration is achieved within 1.5 hours. Because of its elevated first-pass metabolism, the bioavailability of the nimodipine is approximately 13% after oral administration. Nimodipine is transported 95% bound to plasma protein and is metabolized in the liver. The terminal elimination half-life of nimodipine is approximately 8 to 9 hours, but initial elimination is rapid and equivalent to half-life of 1 to 2 hours. Its metabolites are inactive. It is highly liposoluble and crosses the blood-brain barrier. Newton randomized control trial evaluated the use of single-dose intraventricular sustained-release nimodipine microparticle in patients with the aneurysmal SH. High concentration of CSF nimodipine were found, and angiographic vasospasm, delayed cerebral ischemia, and rescue therapy were reduced, but there was no effect on clinical outcome. Now, interaction of nimodipine with the other drug. Nimodipine is metabolized by cytochrome P450 3A4 system and therefore interacts with the drug frequently used in neurocritically ill patients. Drug that inhibit this enzyme increases the plasma concentration of uh, and increases the plasma concentration of the nimodipine are erythromycin, clarithromycin, ritonavir, ketoconazole, voriconazole, itraconazole, fluoxetine, cimetidine, and valproic acid. On the other hand, medication acting as a cytochrome P453A4 inducer and reduces the nimodipine serum concentration are carbamazepine, phenobarbital, and phenotol. So while practicing, we should keep in mind which drugs are increasing the concentration of nimodipine and which are decreasing the concentration of nimodipine. Now regarding route, dosing, and timing of nimodipine administration. Both Neurocritical Care Society and American Heart Association, American Stroke Association guideline support the use of oral and enteral route for nimodipine administration based on the RCTs performed decades ago. So the use of intravenous route has been questioned because of higher risk of arterial hypotension. Hypotension and the blood pressure variability is associated with poorer outcome in patients with aneurysmal SH. However, taking nimodipine with the meals results in decreased peak plasma concentration and lower bioavailability compared with the fasting. Therefore, oral and enteral form might not be interchangeable because oral nimodipine is in the form of capsule and enteral administration can be via prefilled syringe or extracting it from the capsule. Furthermore, in some countries, nimodipine is in the form of tablet and pharmacokinetics of the tablet is not same as capsule, at least in healthy women volunteers. So both route means intravenous and oral can be effective in preventing poor outcome, delayed cerebral ischemia, and neurological deficit. But the problem with the intravenous route is the hypotension. The increasing use of minimally invasive and the invasive cardiovascular monitoring in patients with aneurysmal SAH may increase safety and potentially improve outcome in the intravenous route. It has to be noted that vehicle in the original intravenous nimodipine formulation is almost 25% ethanol. So it can be vein irritating and therefore has to be administered through central venous catheter. Another potential route using nimodipine consists of intra-arterial route. Intra-arterial spasmolysis with nimodipine has been commonly used in patients with direct cerebral ischemia as an option of treatment in patients who did not respond to induced hypertension. However, this is not free of complication, especially on the blood pressure, with the need to increase vasopressor requirement to maintain induced arterial hypertension. Additionally, intraventricular administration of nimodipine has been evaluated, with the maximum tolerated dose was 800 mg. There was no intraventricular nimodipine-related hypotension compared with 17% with enteral nimodipine. Now about dosing and interval. Oral and the enteral nimodipine at the dosage of 60 mg every 4 hourly for duration of 21 days is most commonly administered regimen in the daily practice. Nimodipine associated hypotension may lead to dosage splitting, dose reduction, and therapy discontinuation. About timing and the duration. Oral and the enteral nimodipine administration is usually recommended within 96 hours of bleeding. Therefore, it should be before vasospasm window. That means if you want to administer nimodipine, it should be within 96 hours so that we can effectively prevent vasospasm. However, optimal timing to start nimodipine is still debated. And for example, the quality indicators of Spanish Society of Intensive Care Medicine considered it a standard use or a standard to use it as early as within 12 hours after aneurysmal SH. Additionally, it can be debated how many times should nimodipine be administered. Landmark study used 21-day time frame as supported by guidelines. However, some authors suggest treatment should not be longer than 14 days, which is at least reasonable considering classical timing of high risk window for angiographic cerebral vasospasm. Thank you, guys.